All right, so today we're going to do chapter 24, 27, 28, and 31, perfusion, okay? So by the end of the class, we'll be able to examine side effects, interactions, and nursing care for patients taking positive inotropic agents and other drugs for heart failure. We'll be able to contrast mechanism actions, side effects, interactions, and nursing considerations for loop and potassium-sparing diuretics. Compare the mechanisms of action, side effects, interactions, and nursing considerations for anticoagulants and antiplatelet drug, aggregators, and then planned nursing care for patients taking anti-anginals. So chapter 24, we're only doing loop and potassium sparing. Chapter 27 is all of chapter 27. Chapter 28 is only anti-anginals. And then chapter 31 is only anticoagulants and antiplatelets, okay? Don't do any extra reading if you don't have to. All right, so we're gonna talk about a little bit about the kidneys. So kidneys obviously filter your blood. They regulate your blood volume, they regulate your electrolytes, and they help regulate your acid-basic balances. They secrete different types of hormones that can raise your blood pressure, just regulate your blood pressure in general, stimulate red blood cell production, and then it actually excretes the active form of vitamin D for your bones. So why are we talking about that? Because of diuretics. Diuretics work in the kidneys, and that's why you need to know. Just a quick overview, okay? We don't need to get into all the patho yet. So why is this important? Because diuretics increase your urine flow. So this is for excess fluid wherever, whether it's from high blood pressure, heart failure, kidney failure, liver failure, cirrhosis, pulmonary edema, wherever you have extra fluid, it will help it, okay? So adverse effects, obviously they work too good. Now you're dehydrated. You took all my fluid. Okay, now you took all my fluid, now I'm hypotensive. Or you took all my electrolytes and now I have an imbalance. Okay. So loop diuretics are the most common. We use them all the time. The reason they're called loop is because of the mechanism of action. They block sodium reabsorption and chloride reabsorption in the loop of Henle. That's why they're called loop diuretics. Okay. So they reduce edema associated with heart failures, hepatic cirrhosis, and renal failure. Furosemide and torsemide are also approved for high blood pressure. Furosemide, it's PO or IV. That can be push or drip. It is used for acute heart failure, high blood pressure, excess edema, things like that. It prevents the reabsorption of sodium and chloride in the loop of Henle. Obviously, potential electrolyte imbalances, hyponatremia, dehydration, hypotension, orthostatic hypotension, syncope, and it's also ototoxic, okay? And that is when it comes into the IV form especially. The IV form, if it is really fast, you will have immediate tinnitus as you're pushing it if you push it way too fast, okay? We want to push it slow, we want to follow the guidelines. Okay, it also has a black box warning that it may lead to profound diuresis with water and electrolyte depletion. We want to avoid digoxin, aminoglycoside, antibiotics, corticosteroids, amphotericin B, and other potassium depleting drugs. Okay, and it also can diminish the effects of insulin, and so then that doesn't really lower your blood pressure, your blood sugar. So you might want to monitor the blood sugar for sure. We're going to avoid hawthorn, dandelion, juniper, green tea, and hibiscus. Overdose. You guessed it, high blood pressure. Low blood pressure, severe fluid, and electrolyte loss. So it worked too good. Now the three adverse effects we already talked about, okay? So we just treat the symptoms. If my blood pressure is low, I need vasopressors like norepi. If I have severe fluid loss, I need fluids. If I have severe potassium or sodium loss, give me the supplements, okay? It's pretty straightforward. If you have a hypersensitivity to furosemide, obviously don't take it. But also sulfonamides, we don't use furosemide either, okay? If you are allergic or have a hypersensitivity to sulfonamides, you will also have one to furosemide. Another contraindication is anuria. If I'm not peeing, don't give me something that's going to increase my urine flow, right? If there is some reason I can't pee, whether it's structural, whether there's a kidney stone blocking it, okay? If something is blocking it getting out, or I just can't pee on my own, don't give me something that's going to make my urine production increase because my bladder is going to swell and pop, okay? Bad idea. Hepatic coma. severe fluid and electrolyte depletion. If I'm already dehydrated and have hypokalemia or hyponatremia, don't give me any more Lasix, okay? All right. Tell the provider if the potassium's low. Tell the provider if the sodium's low. Caution when premature infants and neonates. We want to monitor their blood pressure, monitor their INO, monitor their electrolyte values, monitor their kidney function, monitor for signs and symptoms of hypokalemia, which you should know by now. Okay. And then monitor for urine retention. What does urine retention look like? Urine retention is I'm already monitoring their INO and then randomly they stop peeing. Okay. Or they never started. So now I have my bladder can be distended. So you'll have some distension in the lower abdomen. You'll have abdominal pain in the lower abdomen. And it'll definitely be tender on palpation. But you're already tracking their INO. So if they haven't peed, you probably should check. Okay. Also tell them to take it in the morning, because if they take it at night, if I'm 80 years old and I take my fluid pill at night, I'm going to pee all night. I mean, this is for anyone, but especially if you're 80 or older, because they're going to pee all night. And guess what's going to happen? It's dark. They have something on the floor. They're going to trip. They're going to fall. They're going to break their hip. Not good. Okay. Don't do it. Take it in the morning. The other thing you have to think about, nursing considerations, it's not on here. Things you have to, imply. What is the intended action of furosemide, of both diuretics? Increase urine flow. That's what we want to happen. So what do I need to be sure for this patient has? Some kind of way to get to the bathroom safely. Okay. If they can walk, I might need to get a bedside commode, because they're going to be going a lot. Getting a urinal. Okay. I don't even like to use a urinal for them in, because they're going to fill it up fast. Now, if my patient can't walk, we're going to need a bedpan. But more importantly, they're going to have to go, and it's going to be urgent, and it's going to be often. Okay. Things happen where we're busy. We can't go see them right when they need us. So maybe we need to get a catheter or an external catheter, a pure wick, something to catch the urine now, so that I don't have to, they don't have to be inconvenienced. We don't have to be inconvenienced. It can help them go to the bathroom, and they don't have to hold it or anything like that. Okay. Because they're not going to be able to. If they got to go and they're on Lasix, they've got to go now. Okay. And we want to keep them safe. We don't want them tripping or trying to do it themselves, because I couldn't get there fast enough. Okay. Potassium sparing. So this does not affect the lowering of potassium. All right. It can either blocks aldosterone or sodium. And aldosterone we'll talk about in the next slide. So spironolactone is the most common potassium sparing. It's used for mild high blood pressure, reduces edema with CKD, hepatic cirrhosis, slows progression of heart failure, is a primary, and for primary hyperaldosteronism. So aldosterone increases the reabsorption of sodium in exchange for potassium. Okay, so when the aldosterone is released, it goes into the kidneys and it says, give me that sodium, you can have the potassium, and so the potassium and the water leave. So if it blocks that, it's going to keep on to the potassium, and the water is still going to also work on the water. Okay. So it still causes diuresis and the diuretic effect, but it will keep on to the potassium. Some adverse effects, gynecomastia, which is breast tissue in men, or someone who's not supposed to have breast tissue. Okay. And this isn't like just extra tissue. Like, people that are overweight may have like excess tissue, adipose tissue on their chest. This is not the same. This is actual breast tissue. It looks different under a microscope, and they look different like when you see them. It's not just extra tissue. They will actually have a curve to them and look like breasts. Okay. You can also have impotence, diminished libido, menstrual irregularities, hirsutism, which is when male pattern facial hair on women, or someone who's not supposed to have facial hair. Okay. Breast tenderness, hyperkalemia, the signs and symptoms of hyperkalemia, muscle weakness, fatigue, bradycardia. It can also cause tumors in lab animals. So drugs that we want to avoid: aspirin and other salicylics, digoxin, potassium supplements, ACE inhibitors, and ARBs. We're going to talk about ACE inhibitors and ARBs a little later, but most of them are attached to a potassium ion to stabilize them. Okay, so it'll be like lisinopril potassium, or losartan potassium. That is still an ARB, okay? But the potassium ion kind of stabilizes it, so it can be put into a pill form. So it already has a dose of potassium in it. That's why they say avoid it. Other antihypertensives. That doesn't mean that they can't take them. It means that you have to monitor their blood pressure, okay? A lot of people take a lot of blood pressure medicines and diuretics, multiple diuretics even. Okay, so we just have to monitor for hypotension. We want to avoid licorice and hawthorn. Treatment overdose signs and symptoms are drowsiness, mental confusion, nausea, vomiting, dizziness, diarrhea, hyperkalemia. So we're going to treat the symptoms. Usually normal saline will fix it all. The confusion, dehydration, the diarrhea, those kinds of things, normal saline will fix a lot of it because you'll get more hydrated and you won't be so confused. To replace the fluids, replace the electrolytes. Take away the electrolytes if the hyperkalemia is too much. Use the potassium lowering drugs, and then vasopressors like norepi for the hypotension. Once again, a contraindication is anuria. Okay, serious chronic kidney disease. Now this is talking about chronic kidney disease that cannot urinate anymore. So this is basically anuria. Okay, so if my kidneys don't work and I don't pee, and you've given me some, my pee is already supposed to let go of my potassium that I don't need, and it's not even doing that, and now you give me something that's going to hold on to more of it, ain't gonna work because I'm gonna have hyperkalemia real fast. Okay, the only way my kidneys work is on a machine 3 times a week. Don't give me something that's going to alter my electrolytes unless it's going to lower them. Pregnancy and lactation is not approved for that either. You can give it with food because it will actually increase absorption. Don't take potassium supplements. Monitor electrolytes, the blood pressure, the INO, their weight, signs and symptoms of hyperkalemia. Instructed them to take it in the morning. Take it with food. And again, tell them about potassium supplements, salt substitutes, and foods that are high in potassium, like orange juice and bananas. Okay, we don't want any kind of extra potassium with this med. All right, so now we're going to get into heart failure. So we're going to go over a quick overview of heart failure. So this is when your heart can't pump for some reason. Okay, these are some of the reasons that it won't pump. Whether you've damaged the muscle, whether you've damaged the vessels that supply it with blood, and then you've further damaged the muscle, whether you've had some kind of stenosis. So with the hypertension, the dyslipidemia, the mitral stenosis, the stenosis of something in your heart, and so then the pressure is too great to overcome, and so my muscle will get tired and you'll wear it out. Okay, so something has worn it out so much that it can't be fixed. Okay, so there's no cure. We just want to prevent it or slow the progression. So preload, this is the pressure and what happens before the blood enters the right ventricle. Okay, so before the blood enters the right ventricle, the myocardial fibers are stretching. Okay, when they stretch, the farther they stretch, the bigger the contraction. Okay, so drugs that increase preload contractility increase those fibers being stretched, so they make that push easier. So when it pushes easier and contracts better, my cardiac output is obviously increased because I'm pushing so much harder than I was, and so the output from that ventricle is better. Okay, so these are positive inotropic agents. Afterload. So this is the pressure in the aorta that the left ventricle must overcome. Okay, because we all know that the aorta's got that hump, right? That's a lot of pressure. You have to get it up and over. And if that pressure is super high, it can't do it. And my left ventricle is big and fat, and it can't pump anymore. The pressure gets worse and it can't support it. So if we lower blood pressure, we will lower the pressure needed. Okay, so it creates less afterload and decreases the workload of the heart. Okay, so if we lower blood pressure, it will help your heart work smarter, not harder. Okay, we want it to work easily. We want it to be an easy thing for it to do. So that's what we're trying to do. And if we lower the blood pressure, that can help. Okay, left versus right. Left, think lung. Okay, the left side of my heart gets the blood from the lungs and puts it over the aorta, right into the body. If it doesn't pump, it's got to go somewhere, and if it can't go out, it's got to go back. Okay, it's a circle, right? If it can't go this way, it's got to go backwards. It's just like an overflowing cup. So if it overflows, it's going to overflow in my lungs. So that's going to look like crackles, cough, shortness of breath, that rusty sputum, You can have hypertrophy, which is when the muscle like enlarges, okay? So that's my left. My right-sided heart failure, once again, it's like an overflowing cup. If my right ventricle can't work, it's going to back up to my atrium, and my atrium is going to back up to the rest of my body. So it's going to be peripheral edema. Organs are going to be engorged because it's going to have blood kind of pooling there. All right. So right side is the body, left side, heart. All right. So there's 3 mechanisms of actions for pharmacological management. It can slow the heart rate. So that will increase that will help the workload of the heart, increase contractility, or it reduces the workload. ACE inhibitors, ACE inhibitors reduce afterload. It's a drug of choice for heart failure. Enhances the excretion of sodium water, which again is great for heart failure because the less blood volume and the less peripheral vascular resistance, the easier it is for my heart to work, right? If it doesn't have that much blood to pump in the first place, great. Now my blood pressure is even lower. Now it has an easy time, okay? That's what we want. We want our heart to take it easy, and this will help. ARBs work very similar, and they are used when they can't handle the ACEs. So one of the most common ACEs is lisinopril. It's used for heart failure, high blood pressure, and then the off-label use of migraine. Inhibits ACE and then decreases aldosterone secretion. Blood pressure decreases and cardiac output increases. Okay. Most common side effect is a cough. And it's like a dry, non-productive cough, and it's really annoying, and it doesn't really hurt anything. It's just annoying. Okay. That's a very common one. Headache, dizziness, orthostatic hypotension. All those make sense. If my blood pressure is really low or something's like, I've reduced the blood volume, I can have those symptoms, right? Rash, hyperkalemia, because as we talked about earlier, they're usually attached to a potassium ion. Taste disturbances, chest pain, nausea, vomiting, diarrhea, and then angioedema. It also says fetal injury and fetal death when taken in pregnancy. So it's avoided. But the angioedema, that can happen as soon as you start taking it, or it can happen years later. I've seen people come in 10 years after taking it and they have angioedema, which is when you have edema in this area, in your mouth and neck, which is your airway. Okay. So this is a medical emergency. If someone starts having angioedema, we need to get them to the ER immediately. Okay. They will give them the anaphylactic shock meds. They sometimes intubate them if they can see, where they're at, but sometimes it's so swollen they'll crack or trach them at bedside. Okay, so this is an emergency. The patients need to know what angioedema is, what it feels like, what it looks like. It'll feel like a tingling in their throat, in their tongue, and then it'll come on pretty fast. They need to go to the hospital. We want to avoid NSAIDs and diuretics because of the blood pressure. Hyperkalemia with potassium-sparing diuretics. Aliskiren, valsartan, and sacubitril. Valsartan, sacubitril is an Ernesto. It's a newer drug. It's like a combo ARB and ARNI. It's in your book. I would definitely look it up and just be familiar with it. It's also in your drug cabinet. But the reason you don't take that with ACE inhibitors is because you can actually increase the risk of angioedema. Once again, avoid potassium supplements. Avoid salt substitutes. Signs and symptoms. What does lisinopril do? If it works too good, hypotension. We want normal saline and vasopressors because that's about the only way you can get someone's blood pressure up. Okay. Hyperkalemia is a contraindication, right? And then angioedema from other ACE inhibitor therapy. If I've already had angioedema once, I don't need to do it again. Okay. Assess blood pressure prior to administration. Assess renal function because it works in the kidneys. And if your kidneys aren't working, it's not going to do any good. Monitor for angioedema, electrolytes, and blood pressure. Teach them about orthostatic hypotension, rising slowly, things like that. Okay. Diuretics. So we've talked about how they can increase your urine flow and they help with edema. If I have excess edema in my lungs, in my body, this will help because it's going to pull the fluid, the excess fluid, and try to get it out. Okay. It's used a lot of times with all these other drugs. We just have to monitor blood pressure. Beta blockers. We know about beta blockers and how they work. Okay, they reduce the workload of the heart and they have an inotropic effect. So metoprolol, most common one used. Okay, PO, IV, and they have a sustained release or XL version. Okay, it slows the progression of heart failure, angina, high blood pressure, reduces cardiac complications after a heart attack. It's also used for essential tremors, migraine prophylaxis, prophylaxis, and atrial dysrhythmias. Okay. So it reduces sympathetic stimulation of the heart. It works on both receptors, beta 1 and 2. So if your patient has a history of bronchospasms, bronchoconstriction, asthma, respiratory issues, they don't really want to take metoprolol. We'll give them propranolol instead. Okay. So metoprolol works on beta 2. So if we have any kind of respiratory issues, we're not doing it. Obviously, it's going to cause bradycardia, hypotension. That's what it's supposed to do, but it can be severe. You can have abnormal sexual dysfunction like impotence, drowsiness, fatigue, insomnia. It also has a black box warning of if you stop it abruptly, you can exacerbate angina and cause a heart attack. So don't do that. Okay. We want to withdraw it over 1 to 2 weeks. We want to slowly taper it. Avoid digoxin because bradycardia. ACE inhibitors, ARBs, and other beta blockers. That doesn't mean they can't. I know it says interactions and it says all these things. It just means they are at a risk for hypotension, okay? A lot of people take a lot of drugs together. It can actually enhance hypoglycemic effect of insulin, so monitor their blood sugar because their blood sugar may be low. They also want to avoid verapamil. It can also enhance oral anti-diabetics as well. Avoid Hawthorne. Obviously, the overdose is bradycardia, hypotension, bronchospasm. That's literally what the betas do, right? They work too well. It's too much. Too low of blood pressure, too low of heart rate. Now my airway's constricted. So volume expanders, which are going to give you the volume back. It's going to help with the bradycardia. It's going to help with the hypotension. Vasopressors and atropine. All right. Contraindications. Want to guess what they are? Cardiogenic shock, sinus brady, heart block greater than 1st degree. If my heart rhythm is already messed up, don't mess it up worse, right? All right. Hypotension. If my blood pressure is already low, I don't need anything that's going to make it lower. Overt cardiac failure, asthma, and bronchospasm. So those are history of respiratory problems. If they have those, they don't need metoprolol. They need propranolol. Okay. We want to monitor EKG, blood pressure, heart rate. Okay. Assess their heart rate and blood pressure before administration. If it's less than 60 or they're hypotensive, don't give it. I mean, I don't care if they're having a heart attack right now and the cardiologist says give it. If their blood pressure is 70 over 40, maybe we should have a discussion. Okay. We also want to reduce the doses in older adults because they have an increased risk of falls and dizziness. Once again, monitor heart rate, blood pressure, EKG, glucose levels. Take with meals. Monitor for shortness of breath or bronchoconstriction, and teach them not to stop abruptly. So now we have cardiac glycosides. Okay. These are very scary drugs because they have a very narrow therapeutic range. So you have to be compliant. If you're not compliant, you can't take this drug. Okay. It's a second-line treatment for heart failure and improves cardiac output and increases the force of the heartbeat and slows the heart rate. Okay. So digoxin, it's PO, it can be IV. It's used for heart failure and dysrhythmias, increases the contractility of the myocardial contraction. That's all you really need to know. The rest of it is how it works, but it makes sense if you know how, if you know the why, okay? So it inhibits a critical enzyme responsible for pumping sodium ions out of the myocardial cell in exchange for potassium. So it's hanging onto the sodium and then as the sodium accumulates in the myocardial cell, calcium is released, and the calcium and the potassium together provide a forceful contraction because that's what they do. Okay. It has a pretty fast onset. A adverse effect is dysrhythmias, especially if you have hypokalemia or chronic kidney disease. Nausea, vomiting, fatigue, anorexia, visual disturbances. Okay, so you can have digoxin toxicity. So my digoxin level is too high. That's that narrow therapeutic range we were talking about. If it's too high, I'm going to start having those visual disturbances, those halos around lights. So like it'll look like literally a halo around a light, like an astigmatism does. You'll have a green tinge to your vision, or you can have visual blurring. Okay. If you start having any of those symptoms, it's an emergency. You need to stop taking the digoxin and go to the hospital. We want to avoid diuretics, ACE inhibitors, spironolactone, beta blockers, antacids, cholesterol lowering drugs, quinidine, calcium IV, verapamil, amiodarone, and Xanax. Okay. All these medications put you at an increased risk for all of these things: hyperkalemia, hypokalemia, dysrhythmias, digoxin toxicity. We don't want any of these side effects to get worse, and these drugs can cause that. Okay. Potassium supplements and salt substitutes should be avoided. Okay. We already have extra potassium hanging out. We don't need any extra. All right. We want to overdose. There's something called digoxin immunofab, which is like an immunoglobulin for digoxin. It's specified just for digoxin. It will like eat it and take it out. So if I already have a dysrhythmia, which is what an AV block is, or a ventricular dysrhythmia, don't give me this. Okay. Caution with older adults. We know that. Heart attack. Cor pulmonale, sorry, is a heart malformation. Usually in kids, you usually have it fixed once you're older, but maybe it's small and they can live with it. If you have hypothyroidism because it puts stress on your heart, and then bradycardia, tachycardia, and then CKD. Whatever. CKD should receive a lower dose because you can't excrete it, so you can be toxic. So hold the dose if the heart rate is less than 60. And this is not a radial pulse. This is an apical pulse. Okay, apical pulse or EKG monitor only. So I can see it. If it is less than 60, hold it. And if the digoxin level is above 1.8, don't give it. Okay, you have to check before you give it. And if it's too high, you can't. Now, there might be another number you see. Today we're going to be using this. Okay. So monitor for dysrhythmias, monitor for visual disturbances, monitor for bradycardia. Check the medication level before you do it. All right, so now we have inotropic and vasodilators. Vasodilators lower blood pressure, relax blood vessels. It's not really used that often because it doesn't really have the inotropic effects. It doesn't really help except for the lower blood pressure. But then we have the beta adrenergic agonists and the phosphodiesterase inhibitors. Okay, big word. All right, beta adrenergic agonists. Those are like your dopamine. Okay, so they rapidly increase the contractility. They have minimal changes on your heart rate and blood pressure, but we don't use them for forever. Okay, 72 hours unless it's palliative and they're waiting on a cardiac transplant. All right. Phosphodiesterase inhibitors block phosphodiesterase. They increase calcium for the contraction, kind of like the judge, but not as deadly. So positive inotropic response and vasodilation increases the contractility and decreases afterload. Short-term therapy only. So one of those is called milrinone. Milrinone is a positive inotropic drug, phosphodiesterase inhibitor. Short-term therapy for heart failure. Okay. Increases the force of the myocardial contraction and increases the cardiac output. Pretty fast onset, okay? 1 out of 10. I'm gonna say that again. 1 out of 10 have a ventricular dysrhythmia, which is not good, okay? Hypotension, headache, nausea, vomiting, are also other side effects. We want to avoid disopyramide, which can cause hypotension, digoxin, dopamine, and inotropic drugs. No food interactions, overdoses of hypotension. So give them normal saline and vasopressors. If you have a hypersensitivity to the drug, don't take it. And if you have a pre-existing dysrhythmia, don't do it because 1 in 10 have the dysrhythmia. And if you already have one, you're probably going to be one. Okay? You have to use a micro drip set and a pump. You can't just straight hang this. You can't push it. It's on a pump. Okay? Monitor their heart rate. Monitor their blood pressure, monitor their EKG, their electrolytes, their INO, their renal function. Okay. It's got a very narrow titration if you have to titrate the drug. So definitely want to monitor that heart rate and blood pressure and the EKG. Okay. All right. So now we're in the angina pectoris. This is chest pain. Okay. is when your heart doesn't have enough oxygen for some reason, whether it's a clot, whether it's not just a clot, but it could be plaque, structural, whatever. Something is happening now. My heart isn't getting oxygen. Okay, so you can have stable. Stable is stable. I mean, it is what it is, right? Don't think too hard. If it's stable, that means it's happening. I know when it's going to happen. I know how long it's going to happen, and I know what's going to help it. Okay, I know it's how bad the pain's going to be. So I know I'm going to go on this walk around the block, and I know it's 99 degrees outside. I'm going to get some angina, okay? Because I know I have stable angina. Now, if I had unstable angina, I have no idea when it's going to come. I don't know how long it's going to last. I don't know what's going to help. And it doesn't get better with rest. Okay. Stable angina is relieved at rest. That's the biggest difference. If I can relieve it by sitting down and taking a breather, then it's stable. If it's unstable and the pain persists even when I'm resting, it's not good. Okay. You can have another one called spasms from vasospastic angina from spasms of the coronary arteries. Then you have silent ischemia, so you don't even have the anginal pain, but it's happening. All right, so therapeutic outcomes. We want to reduce the intensity and frequency and improve exercise tolerance. So either we're going to terminate the episode or decrease the frequency. We're going to slow the heart rate, reduce preload, reduce contractility, and lower blood pressure, because that will increase the amount of oxygen available and decrease the demand for your heart. Okay, organic nitrates are like the biggest ones we use for angina. All right, they reduce heart workload, lower myocardial oxygen demand. It works on both arterial and venous smooth muscles, so they dilate arteries. That's important, because if it dilates arteries, it does it everywhere. Okay, not just in the heart. So we use it for, and this is nitroglycerin. It's sublingual, IV, aerosol, topical, transdermal, and it's even a PO. It's used for angina. It's a potent vasodilator. Okay. It's pretty fast onset. It can dilate your cerebral vessels. So if I have an increased blood flow to my head, what's going to happen? Have you ever stood on your head? Or it's an increased blood flow to your head. Okay. You get a headache. That's why. You get increased blood flow. All right, you can have reflex tachycardia and obviously hypotension, which is not listed on there, but it's a vasodilator, so it's going to cause hypotension. Do not use this. It is definitely avoided with phosphodiesterase 5 inhibitors, because which is like Viagra, Cialis, or those are the generic names of them. They work the same. They both vasodilate. So if I've had a Viagra, same day I have a heart attack, and you give me nitro in the hospital, you're going to vasodilate me even more. I'm going to die, because it's going to be, there's no way my heart will be able to pump. Okay. It's going to be too much. All right. So avoid those. We want to avoid alcohol and antihypertensives because of hypotension. Hawthorne, we want to also avoid. The signs and symptoms of overdose is hypotension. We treat that with normal saline. There's also, you can use methylene blue if there's a certain, if you have a suspect that this is going to happen, the myomoglobinemia. Okay, so if you have pre-existing hypotension, obviously don't do it. Makes sense? The blood pressure is already low, don't make it lower. Okay, if I have a high intracranial pressure, okay, so I have a bleed, I have something going on in my brain that's making the pressure really high. When I vasodilate, I'm going to increase the pressure in my brain, okay, which is going to cause hernias in your brain, and then you die. So if I already have head trauma or an increased intracranial pressure, don't give me anything that's going to make it worse, okay? If I have pericardial tamponade or constrictive pericarditis, that is because you're going to increase the oxygen allowed in the heart. You're going to vasodilate the coronary arteries, and that can actually make these things worse. And these things can make the nitro work not work, because it's already squeezing it too hard. Okay, we don't want to mess with it. All right, the sustained forms should not be given to patients with glaucoma, dehydration, or hypovolemia. Okay. The very weird thing about nitro is that it has to be in a glass bottle. and it's usually like a brown bottle. If you use the IV form, it has to be with special IV tubing because plastic will absorb the nitrate and then you're just giving someone normal saline. It doesn't work. So it has special tubing, and also the tubing protects it from the light. It's like blue. Sometimes it's not plastic, and so it doesn't absorb. And so you have to use the appropriate IV tubing. Also, once you hang the bag up, you need to cover the bottle with a brown plastic bag to protect it from the light. Use gloves when applying the paste or patch. I feel like that's pretty self-explanatory, right? Because I don't want to get the nitro on my body. Okay? Because then it's going to work for me, and then I'm going to be hypotensive and I'm going to pass out. So monitor for a headache. It's going to happen. They're going to get a headache, and you're just going to be like, I'm sorry. It's working. Okay? Give them some medicine. They can take like medications for pain. And monitor their blood pressure, obviously. And if you're going to defibrillate them, wipe off the paste, because the paste goes right here on their chest, okay? Or the patch. It goes right here. So take them off, wipe the skin before you defibrillate someone on top of it. That's for anything, but especially this, because nitroglycerin is used in like TNT. So advise them if the pain is not relieved after 5 minutes. So the typical instructions are, if you're having angina or chest pain, you take a nitro. In 5 minutes, if the pain isn't better, take another one. In 5 minutes, if it's not better, take another one, but that's the max dose. That's all you can take is the 3. But if it's not relieved after the first dose, go ahead and call 911, because by the time they take to get here, you'll have taken all 3 doses, okay? We don't want to wait to the 3rd dose and then it's still not working and then you got to wait, okay? It needs to be stored in a cool, dark place and tightly closed. Avoid alcohol. And tell them if they're going to be in a stressful situation, take an extra dose, okay? So if I know I'm about to go on a hike or a walk or whatever I'm about to do, I might want to take one if I know I'm going to have the angina, the stable one, right? So beta adrenergic blockers, they can use beta blockers to actually help with angina. So this reduces the workload of the heart. It's a first-line drug for angina. We'll talk about the side effects. So atenolol. These are all the O-lols, right? It's used for heart failure, high blood pressure, angina, heart attack. So it selectively blocks. This one selectively blocks beta 1. Okay. Adverse effects: fatigue, weakness, bradycardia, hypotension. Abrupt discontinuation can cause reflex angina. Okay. So drugs that we want to avoid: calcium channel blockers, digoxin, antihypertensives, and anticholinergics. Overdose, hypotension, bradycardia. Okay, that beta 1, that's what it does. If it works too well, now I have hypotension that's too much, bradycardia. Okay. Atropine, isoproterenol, and then even hemodialysis is going to help. So contraindications: if I already have bradycardia, don't give it to me. If I already have a heart block, don't do it. Cardiogenic shock, decompensated heart failure, which is like end-stage heart failure, or severe hypotension. So if my beta 1 is already obviously being stimulated somehow, don't do it. Okay, I'm already having the bradycardia, I'm already having hypotension. I don't need anything to make it worse. Monitor heart rate and blood pressure prior to administration, during, and after. If the heart rate is less than 60, do not give it. Monitor for hypoglycemia as well. Avoid abrupt discontinuation. All right, so now we're into calcium channel blockers. So this inhibits the transport of calcium into the myocardial cells. It relaxes smooth muscles in the arteries. Reduces cardiac workload, brings more oxygen into the myocardium. So cardizem, ditalazem. It's called ditalazem. A lot of people call it DILT. It's used very often, not so often for angina, but we do use it a lot for the atrial dysrhythmias. So it's stable, variant angina, high blood pressure, and atrial dysrhythmias. So then we talked about how it works, okay? It's semi-PO or IV, and it's even got an extended release, usually with the PO. Side effects: headache, dizziness, edema to the ankles and feet. Abrupt withdrawal may participate in acute angina. It seems to be very common. So avoid digoxin, beta adrenergic blockers, ethanol, which is alcohol, beta blockers, we already talked about those, antihypertensives, and dalterone. Avoid St. John's wort, ginseng, garlic, and hawthorn, and golden seal. Overdose, we treat with atropine and isoprotenolol, sorry, to reverse bradycardia, and vasopressors, like dopamine or dopamine, to reverse hypotension, calcium chloride, because this is going to inhibit calcium. So now we're going to give them calcium. So it will help reverse the hypotension and heart block. If I'm having a heart attack, if I'm having a heart block, sick sinus syndrome, which is a dysrhythmia. Okay. If I'm having anything already going off my heart, I don't need anything else affecting it. Okay. Severe hypotension. If I have a bleeding aneurysm, we don't want to give DILT, or intracranial surgery, chronic kidney disease, and hepatic impairment. Okay. So if you're going to give it IV, you have to have cardioversion equipment available. Okay. Because if you're giving it for the dysrhythmias, especially, if you give it, you have to have that continuous monitoring, and because you can have someone either go into the dysrhythmia or it gets worse instead of better. So we want to make sure we have some kind of emergency cardioversion equipment available. The extended release form should not be chewed or split, and they are not interchangeable. Okay, IR and the ER, they're not interchangeable. Monitor blood pressure, monitor heart rate, monitor their EKG. Hold if the heart rate is less than 60 or the blood pressure is less than 90. So now we're on to anticoagulants, which these should be, you should have known some of these from, being in the hospital from Pharm 1. Okay, so they prolong bleeding time, but why do we use them in heart failure? The reason why is because if we thin the blood, it'll be easier to pump. Okay, because if the blood's super thick, that the ventricles are having a hard time pushing. So if we thin the blood, it actually helps the heart work better. Okay, it can prevent thrombi from forming as well, especially if they have some other kind of stenosis. We don't want any other clots getting in there. Heparin's pretty much the drug of choice, but there's also low molecular weight heparins like Lovenox, enoxaparin, sorry. And then there's antithrombins. So heparin, we can give sub-Q or IV. We're going to focus on the IV form in Pharm 2. So it's prophylactic or for treatment of thrombotic events. They have a weight-based nomogram based on your APTT, which is your proton thrombin time. Okay. Inhibits clotting factors by binding to antithrombin 3. Pretty fast onset. With sub-Q, IV is probably even faster. So obviously an adverse effect, if it works too well, I can bleed. Okay. I can have thrombocytopenia, which is when thrombo is blood, cyte is cell, penia decrease. So my blood cells decrease. Okay. HIT, which is when you have really heparin-induced thrombocytopenia, that's HIT. It can cause a thromboembolic event. Okay. Black box warning. If you're having an epidural or a spinal hematomas after spinal or lumbar punctures, sorry, that's not what it's saying. It can cause epidural or spinal hematomas after spinal and lumbar punctures, can result in long-term paralysis. So if you give heparin after someone's had a spinal or lumbar puncture, they can have a risk for hematomas, which can cause lifelong paralysis if you cut off the blood flow too long. Okay. Want to avoid warfarin, drugs that inhibit platelet aggregation, nicotine, digoxin, tetracycline, and antihistamine. Okay, so it says to avoid other blood thinners, but a lot of times people that are in the hospitals, especially, they're on multiple forms because they need something that works on platelets and on thinning the blood, actually. Okay, so take these interactions with a grain of salt. Just know that if I'm on 2 of them, I better be watching out for bleeding. Okay. Contraindications. If I'm actively bleeding, if I have a bleeding disorder, okay. If I have severe high blood pressure, because severe high blood pressure can lead to an hemorrhagic stroke, and then I'm going to bleed out because I'm on heparin. If I have a recent head trauma, because I could be bleeding in the brain. If I have an intracranial hemorrhage, because I can have an increased risk of bleeding. Bacterial endocarditis is another one. So if you are using the nomogram, follow it correctly. And if you don't know how to follow it, you need to ask for help, okay? Never aspirate or massage the site if we give it sub-Q. And it's most likely usually in the abdomen, okay? We don't really give heparin or any blood thinners anywhere else. They go in the lower abdomen. Elderly patients should be started at a lower dose because they have a risk of falls. Monitor their APTT if it's IV for especially. Monitor for bleeding. Teach patients and family about over-the-counter meds and bleeding risks. So this is what a nomogram looks like. This is just one that a friend actually I've used before, okay? So this is for acute coronary syndrome or AFib. We're going to read this side before we read this side, all right? So the initial bolus is 60 units per kilogram with a max of 4,000 units. So when you do the math, if it's over 4,000 units, we're only giving 4,000 if they're like a very obese patient, okay? So you give them the bolus and then you start the infusion after, okay? The infusion is 12 units per kg per hour. We want their goal of their APTT to be 60 to 80. Okay, so as soon as we start this heparin, we better order a stat PTT. Okay, enter, order, and obtain. Sorry. So you want an APTT right when you start it. You want one 6 afters after you start it. So you need to know when you start it. It's very important that documentation is on point, and it is to the minute, because 6 hours later I have to redraw their blue top, their APTT. Okay. If it's less than 40, which means it's super low and the blood is not thin enough, okay, we want to increase the infusion. So now we're over here, increase by 4 units per kg per hour from the previous rate. You want to order a bolus of 60 units, another bolus, and then repeat it 6 hours. So this tells you if the APT is this is what you do. If it's this is what you do. So you just have to read the instructions and don't get overwhelmed, okay? I'm not saying you have to memorize this. Please do not memorize this, because every place you ever go will have a different one that they want to use, okay? But you definitely need to know how to read this, okay? And if you have questions, please ask. But it tells you what to do, okay? Do a practice problem, give yourself a kilogram, make up some numbers, and do practice problems with this, because I can guarantee you this isn't easy, okay? And it's going to take practice. All right, so anticoagulants, vitamin K antagonists. So they have an immediate onset of action, but they require a close medical supervision. Okay, so that's warfarin. Warfarin is a vitamin K antagonist. We use it for prevention of stroke, heart attack, DVT, PE, prevent high risk thrombotic events, for patients following an MI and AFib episode. Okay, so if you're going to have a clot, warfarin. My grandmother took this for years, hated it. We'll get to why she hated it, okay? Obviously, if it thins my blood, so vitamin K, we know, helps your blood clot, okay? So if it's an antagonist of vitamin K, it's going to take away the effects of vitamin K, and then now it's going to help your body not clot, okay? Abnormal bleeding. I mean, that makes sense, right? If I'm taking a blood thinner, an adverse effect is abnormal bleeding. The big thing, black box warning, is major or fatal bleeding if the INR monitoring is required. So this is a different medication, a different drug. Lab value. This is your INR, okay? The other one was your APTT. This is your INR, okay? So we want to avoid alcohol, NSAIDs, diuretics, SSRIs, antidepressants, steroids, antibiotics, vaccines, and vitamin K. Okay. Why do we not want to use these drugs or alcohol, NSAIDs, vitamin K? Because it's going to disrupt my bleeding okay? It can be either increased or decreased bleeding. Food we want to avoid: green tea, ginkgo, feverfew, garlic, cranberry, chamomile, ginger. Most importantly, vitamin K foods. If I increase the vitamin K available, the warfarin is not going to know what to do. Okay. A lot of times these people have crazy doses. Okay. On Monday, Wednesday, and Friday, they take a 2.5. And on Sundays and on Tuesdays, they take a 5. And then on Thursdays and Saturdays, they take a different one. I'm talking crazy things. Okay. But if it works for them, it works for them. So if I only take a 2.5 every day, okay, it's like a lower dose, right? And now I'd have a lovely kale salad. Okay. Now I've just increased the amount of vitamin K available in my body. And that 2.5 of warfarin is like, what the heck? I can't inhibit all this vitamin K. So it's not going to work and you're going to clot. Okay. Does that make sense? Foods: kale, spinach, turnip, mustard greens, broccoli, Brussels sprouts, cabbage. So you're going to think, oh, it's all green vegetables, but that's not true. It's these. Okay. So this is the list you need to know. All right. This is why my grandmother hated it, because she hated not being able to eat a salad. Okay. She said she wants a salad every now and then. Whatever. I'll talk about more about that in a second. But treatment overdose. Okay. If I have a vitamin K antagonist and it's working too good, what's the treatment? What's the antidote? Vitamin K. Just give them vitamin K. They can give it to an IV. So PO or IV, there's something called K-Centra, which includes factor 2, 7, 9, and 10, which is a complex concentrate of prothrombin. Okay. Vitamin K is the antidote. All right. So obviously, don't give me blood thinners if I've had recent trauma. I have active bleeding. I have a bleeding disorder. I have intracranial hemorrhage. I have severe hypertension, bacterial endocarditis, or severe liver or kidney disease. Those make sense. We've already talked about why, right? Cannot be used in pregnancy. All right. The other thing we want to do is to monitor for bleeding. You want to tell them to use a soft bristle brush, because gum bleeding is common, especially if you have gingivitis. Okay. Overall bleeding, if they have like increased bruising, especially like there's certain spots on your abdomens that you'll learn when you get to trauma that they need to be looking out for. Okay. Teach them the importance of compliance. If they are not going to be compliant, they are not taking warfarin. Okay. Because they have to get their INR checked weekly, monthly, bi-weekly, bi-monthly. Everyone's different. Your INR is your international normalized ratio. It doesn't matter what it stands for, because what it does is it measures how long it takes for your blood to clot. So if I have a very small number, my blood is clotting really fast and the warfarin is not working. Okay. If it's very high, my blood's clotting way too slow and I'm going to bleed out and die. I'm not even kidding. They could, like, we'll talk right here. Okay. So the very last point, teach them if they fall, they have to go to the ER. This is with any blood thinner. If you are on a blood thinner and you fall, I don't care if you hit your head or not, you need to go check. Okay. Things happen during like events like that. You don't know if you hit your head or not. Go get a head CT. Okay. We need to make sure you don't have bleeding on the brain, because it can happen like that. Okay. In Mississippi, at least, where I worked in the trauma center, that was an automatic, I think, Bravo, which is like level 2, our code 2. We have 1 and 2 for our traumas. If someone was on blood thinners over the age of 65 and fell, automatic Bravo, because they needed a head CT now to make sure they weren't having a brain bleed, because it happens so easily. Tell them to use an electric razor, because we don't want them to cut themselves. And here's the thing, they can have vitamin K foods, they can have a salad, but they have to have it every day for the rest of this treatment, because that is the same amount of vitamin K you're getting every time, and they can adjust your doses because of it. Okay. So if I have kale this day and spinach this day, as long as I'm having the same amount of vitamin K and I'm looking up how much it is, that's okay. I just have to do it every day forever. Okay. And that's what my grandmother hated. She said, I don't want it every day. She was ornery. She got switched to another medication. But warfarin it's kind of like DIG. You have to be able to be compliant or you can't take it, okay? All right, so now we have some other kinds. We have 2 parental drugs for thrombin inhibitors. These bind irreversibly to the active site of thrombin and prevent formation of fibrin clots. But then we also have our factor 10A inhibitors. So this is our Eliquis. So this is just another blood thinner. Okay, it works on factor 10. So like the other one worked on vitamin K, one worked on antithrombin, this one works on factor 10, which is a part of your clotting cascade. Okay, so it's important alternatives to warfarin for stroke prevention. It's a PO medication that blocks the formation of thrombin by binding to the factor 10 in the clotting cascade, what we just said. It's an oral only. There does not require routine monitoring. The antidote is the Indexa. I'm not going to try to say that. Okay, this is a brand new drug. It's very, very new. Okay, like maybe the last year or two. So it's new, but it does have an antidote. So we have an antidote for heparin, which is prothrombin. We have an antidote for warfarin, which is your vitamin K, and we have an antidote for your Eliquis, which is this Indexa. Okay. So now we're going to get into some antiplatelets. So antiplatelets prolong bleeding time by interfering with the platelet aggregation, which is how they like clump together. Okay. So it prevents thrombi formation after strokes or heart attacks. A lot of times this is you've had an event, so now they put you on this. Okay. This includes aspirin, ADT, glycoprotein, 2B and 2A receptor antagonists, and drugs for intermittent claudication. I'm sorry. So clopidogrel, that's the most common one. Okay, it's a very, very popular antiplatelet. It reduces the risk of heart attack and stroke. It's also used to prevent clots after having a coronary artery stent or a carotid stent. Okay, we give this all the time. Especially if you put a stent in, you had to get aspirin and clopidogrel. Brilinta and clopidogrel before you left the IR suite. Okay, so it inhibits platelet aggregation as a 24-hour onset. Okay, it can start working before that, like 5 to 7, but the onset is 24 hours. Okay. So you can have flu-like symptoms, headache, dizziness, bruising, rash, pruritus. Okay, the black box warning is poor metabolizers will exhibit less therapeutic effects. We know that, right? If your metabolism is altered, it's not going to work that well. You can have an increased risk of cardiovascular event, obviously. If it's not metabolizing well, if it's not being used properly, it's not going to work. Asian descendants usually have some kind of genetic problem that causes this. Okay, so drugs we want to avoid: other anticoagulants, antiplatelets, fibrinolytics. Yes, the anticoagulants, antiplatelets. A lot of times people are on combos. Okay, that's okay. We just need to monitor for bleeding. NSAIDs, that's a big one. It's a big no-no. Don't need any extra aspirin, okay? Unless it's like right after the stroke and you had the aspirin before, okay? Barbiturates, rifampin, carbamazepine, azole antifungals, protease inhibitors, erythromycin, verapamil, zaraflucast, fluoxetine, and marijuana and PPIs can all interfere with clopidogrel. Feverfew, chamomile, ginkgo, fischl, ginger, and garlic. The 3 Gs, okay? And those are the big ones for clotting. This can affect it. There is no antidote. So this is the only one that does not have an antidote that we have learned so far. A platelet transfusion is what's needed though. Okay, so no medication antidote. You have to replace what they don't have if they need more platelets to help clot. Contraindicated with active bleeding. Okay, do not crush or split the tablets. They need to stop them 5 days before having surgery. Monitor for bleeding, tell the dentist before they do procedures, okay? So that ends perfusion. There's a quiz on there for your weekly attendance. There's a discussion board if you have any questions. Please ask them. If you don't understand, please ask questions, okay? Do your readings, study, and practice your math still, okay? Alrighty, and that's it. Thank you.